Morning, guys. So I'm Angus. For those of you who haven't met, I'm one of the registrars here. I've been given the brief about talking about cardiogenic shock and pathophysiology of left and right ventricular failure. So I'm not an expert, but I am an enthusiast. Apparently, when I was 2 years old, my dad asked myself and my sister, who was 5, what we thought the most important thing in life was. Apparently, my sister said to read a lot. And apparently I said to keep your heart beating, which was clearly incorrect, because the most important thing is perfusing your brain. And later we'll hear about mechanical support and ECMO and so on, which would do that for you. But it was not bad for a 2-year-old. So where have we gone? We've skipped ahead. So our aims for today, we're going to talk, come on. We're going to review the definition of cardiogenic shock, its epidemiology, and how important it is to us in retrieval. We're going to describe the pathophysiology of left and right predominant cardiogenic shock through some case examples, and we'll review some management strategies of those, and then we'll have a look towards the future and what's coming. So cardiogenic shock is estimated to affect 5 to 12% of all acute MIs. There's loads of causes. I'm not going to go into all of that. And the mortality is still very high despite advances in care. The biggest advance in reducing mortality from cardiogenic shock has been coronary revascularization acutely, and we actually don't have any robust evidence that supports the use of inotropes, vasopressors, or mechanical support devices. We just don't have that evidence. We think they work and help, but it hasn't had a significant improvement in mortality. So what is cardiogenic shock? We can think about it like a traffic jam. So no one's getting where they need to go, the perfusion is poor, and everything is backing up behind us and causing congestion, much like my drive-in today. So the principal components, your perfusion will be low, and so you're going to be cold, okay, peripherally, clinically, and your filling pressures are typically elevated, okay, so you're going to be fluid overloaded. And you'll be wet. Okay, so the cold and wet phenotype, that bottom right in the Forrester classification, which does have its flaws, but it's a good concept. These are the big, bad, sick cardiogenic shocks. We're not going to fix these patients with diuresis or fluids. We'll come into that later. But it is, the criteria sort of vary. All trials use different things. And so we know that normal blood pressure doesn't equal perfusion, and people have come up with different ways. So recently there's been the development of the SKY classification, which is a little bit more, a little bit less defined, but probably good for describing between clinicians what's happening. It focuses more on a clinical picture. Where is the patient in this? And they go from being at risk, so not in cardiogenic shock, to beginning to classic cardiogenic shock, where we're thinking hypotension, hypoperfusion, then deteriorating. These are patients who are on multiple inotropes or pressors and are still deteriorating. And then you have your patients in extremis, who may be having mechanical support, maybe on ECMO, maybe actively in arrest. And then there is the arrest modifier, the A. So people will say, you could say that the patient is in BA because they came in VF arrest, we shocked them, and they're having an MI, but at the moment they're not in cardiogenic shock anymore, but they have already been in arrest. So we're going to use this as our framework for the cases and stuff that we'll talk about later. I'm not going to go into all of this. There are biochemical and hemodynamic markers to help differentiate the stages. We can look at that in our own time, because there's quite a lot to cover. So questions for us, is it cardiogenic shock? Probably the biggest question that is probably least asked. And the biggest problem probably with cardiogenic shock is that people go, oh, it's a sick patient, there's clearly septic shock, and they give them loads of fluids and the patient deteriorates. So first question, is it cardiogenic shock? And what's the severity? Where are they at on that SKY stage? Is it LV? Is it RV? Is it biventricular? Is it another cause? Is it valvular, outflow tract obstruction, tamponade? I'm not going to go into those. Okay, we'll cover those in other talks later on, and there's just too much for us to think about those today. Is it medical or surgical? Do they need a cardiothoracic center? Do they need PCI? And then what are our supportive management therapies, and what are our definitive? And then for us especially, does the patient have escalation limitations that would prevent us doing various things, or means they're not in the patient's best interest, or geographically, are they a candidate for ECMO, but they're just so far away that time-wise, that's just not appropriate. So I'm a bit of a nerd, and cardiac stuff is my favorite thing, but I appreciate it's massive and it can get really complicated. So I'm going to try and be really good and stick to 1 or 2 equations and maybe 1 graph. So I think this is the most important equation when we're thinking about perfusion and shock. Okay, it's the equation for flow. It's a pressure difference from A to B divided by its resistance. Okay, and we can apply that to both the systemic and the pulmonary circulation to understand cardiac stuff better. So your venous return comes to the right ventricle, and it's actually the right ventricle that determines your cardiac output. That passes your venous return to the left ventricle via the pulmonary circulation, which hopefully has a low resistance. The left ventricle then powers and increases the pressure into the systemic, the mean arterial pressure into the arterial system. And the role of the left ventricle is actually just to maintain a good arterial pressure and charge it with pressure such that organs can then take from that pressure and auto-regulate their own perfusion pressure. That's what the LV does. The RV actually determines the cardiac output. So the LV keeps that map up whilst trying to keep the left atrial pressure down, and the right ventricle passes it through the pulmonary circulation whilst trying to keep the right atrial pressure down. And that is key, because if we look at physiological parameters of death in patients with cardiogenic shock, this is from the Cardiogenic Shock Working Group in the States, they looked at over 1,400 patients with cardiogenic shock, and they all have PA catheters and all sorts of them. Measured loads of variables, and the only linear correlates of death are mean arterial pressure and right atrial pressure. As your mean arterial pressure goes down, which makes sense, and as your right atrial pressure, the back pressure to venous return, goes up, your mortality increases. Nothing else has a linear correlation with death. Okay, and that equation top right, your MAP minus your right atrial pressure divided by your systemic vascular resistance. It's your systemic flow through your systemic organs. And so obviously if pressure A goes down, pressure B goes up, your flow reduces, your perfusion to your organs reduces. So if we look at metabolic predictors of death, we know obviously these patients will develop multi-organ dysfunction. And as your sky stage increases, the number of organs and so on is likely to worsen. They also, at severe ends, can develop systemic inflammatory response and hematological problems like DIC with the release of inflammatory mediators and so on. But the best predictor of prognosis is lactate at 8 hours after recognition. Not lactate clearance, the best predictor is lactate at 8 hours, and less than 3.1 is the best predictor of a good outcome. So assessment, I'm not going to go into in great detail. You guys all do this every day. You know what you're doing. Clinical assessment, obviously ECG. Are they in VF, VT? Are they having a STEMI? Echo is probably the key. Is it LV, RV? And also echo, you can have a look at your IVC. It gives you a rough eyeball of right atrial pressure via, it's the same as your central venous pressure. And then bloods. We want to know what their lactate's doing and what their organ failure is doing. So, is it left ventricle? Is it right ventricle? Is it biventricular? The two ventricles are a team that work together. Occasionally one of them gets selfish and sort of tries to handle itself because it's failing, and that can sometimes cause problems for the other one. From the Cardiogenic Shock Working Group, we know that actually, despite the sort of traditional thinking that most cardiogenic shock is due to LV failure and just failure of that blood pressure, actually over 50% of cases involve the right ventricle and are either RV predominant or biventricular, okay, the majority being biventricular. As you go up down those sky stages and patients get worse, the amount of RV involvement increases significantly. And actually, your LV predominant shock decreases. Okay, they may have LV involvement, but you're more likely to have RV involvement as you go down. And we know patients with pulmonary hypertension and right ventricular dysfunction have massive mortality. So at 1 year after an admission with right heart failure, mortality is 50% if you have pulmonary hypertension. That's huge. So we're going to go through a couple of cases now, and I'm going to try and work the physiology into these. I'm very happy for people to sort of jump in at any point. I was keen to do some sort of interactive Menti thing or whatever, but actually there's so much, I just wanted to try and keep time. So our first case is a 60-year-old female. This is a retrieval case. She'd apparently had an admission 3 weeks before with a CVA, and she'd had a high trop at that point, so they did an angiogram, which apparently was fine. She had an echo, which apparently was fine. And she went home for a few weeks, and then she returned with a few days of malaise, sort of fever, flu-like symptoms, cough and vomiting, and she's hypotensive. She's on 3 liters nasal cannula. She's got a bit of ST depression that's not moving. She's got a little bit of a trop rise, and apparently the doc on scene says that there's some LV dysfunction on her echo. So she gets treated as an NSTEMI, and they give her some crystalloid because she's hypotensive. So let's talk about the left ventricle. He thinks there's left ventricular dysfunction. So we're going to go through it in the parameters that contribute to cardiac output. The principal determinants are preload, contractility, and afterload. Okay, I don't want to teach people to suck eggs. I know a lot of people will know this. Others, this will be a bit more new. With contractility comes perfusion because you can't beat unless you're getting enough oxygen to fuel that. There's also rate, rhythm, synchrony, which is very important, and myocardial oxygen consumption. I'm not going to go into those. I'm going to try and keep it relatively simple. So the LV, in summary, is very muscular. It can pump literally your entire life. It's got quite a lot of redundancy in that it can make massive pressures and it can deal with high afterload. But actually, we know that there's people walking around with ejection fractions of 15% who maintain a reasonable blood pressure and cardiac output so long as they don't run a marathon, and that's fine for them. It's a bit stiffer than the right ventricle, so it's less tolerant of fluid, which is good for us because it means when we flood people with fluids, they develop a bit of pulmonary edema, and that gives us a clue that there's something we need to do, and we probably give them too much fluid rather than their organs starting to fail first. And a good, healthy left ventricle is super comfortable with afterload. That's its job. Okay, the afterload goes up and it beats harder, and it's fine. It's perfused only during diastole. Therefore, when you have tachyarrhythmias, and we reduce that diastolic time, the LV struggles more than the RV. Okay, this graph again. So LV preload. So we can think of it principally as volume. When we volume load, we increase preload. We move them along that x-axis. Okay, as we do that, it's normally it's a complex definition, preload. Some people will say it's volume, some pressure. It doesn't really matter for us. It's the volume in the LV that it has to work with to eject. Normally we give fluids first line in hypotension to try and increase cardiac output through the Frank-Starling mechanism, which is this graph here. This is actually not the principal mechanism through which the LV increases its cardiac output. It normally squeezes harder, it increases its contractility through something called the ANREP effect, and we'll come to that a bit later. So that is an increase in contractility, and that's actually really what we want. We want to increase our cardiac output for the same preload. That'd be great. So that's what the normal LV does. But however, our failing LV, such as this lady, is down there on the red line. And we can see that the perfusion is inadequate. We're below that horizontal warm area. And that if we increase preload, we're not going to increase cardiac output significantly. So, however, the left atrial pressure is increasing, pulmonary edema is likely to result. So, elevated left atrial pressure causes pulmonary edema, and it increases right ventricular afterload. It's going to reduce the flow through the pulmonary vasculature. So, if you're assessing a patient with left ventricular failure, what do we want to do? Well, we give them volume if they're truly hypovolemic, if they're to the sort of left side of that curve, and you think that unit can increase cardiac output significantly with a fluid bolus, do that. But many of these patients are going to be volume overloaded, in which case you want to reduce their preload. Okay, we use diuretics, GTN, PEEP, okay, which will help with the pulmonary edema. So our patient has clearly had some fluids. She's failed to respond. We're told that they're starting her on some noradrenaline, and they're starting to add some low-dose dobutamine at this point. This is when we leave. So where is she now on this? Okay, so she might have been B, she had some hypotension and so on. She's clearly now into C or D. She's having 1 or 2 agents. Okay, you can see her left ventricle's not working particularly well. I'm not going to go into echo in a lot of details because I know Jimmy and Chris can do that later. Okay, you arrive, and she's now been started on BiPAP. She's on max dose NORAD, she's on max dose dobutamine, and she's on pretty much half max dose adrenaline as well. She's still cold, she's conscious, and her BP is still 60 systolic. So where is she at now? She's definitely stage D, and she's sliding, and she's really falling off. So do we think it's LV? Do we think it's RV? Do we think it's both? It's principally LV failure. There might be a bit of RV involvement, but for the sake of this, we're going to call it LV contractility is the problem. So what do we do next? Let's think. We said contractility is the problem, so let's talk about that quickly. When you have impaired contractility, such as an ischemia, the only way that the LV can increase its or maintain its stroke volume is to dilate. Okay, if you imagine that normally you eject 55% of 100 mils, okay, and then your ejection fraction drops to 15, 20%, the only way to maintain that stroke volume is to take more volume, to dilate. So that's what the LV does, and that's appropriate compensation. But when your contractility is significantly decreased, you can no longer handle your afterload so well as well. And actually, the American Heart Association defines heart failure as those patients who can't increase their contractility, and the only way they can maintain their output is through dilation. So what do we want to do? We're going to try and support her blood pressure, and we want to reduce the afterload so actually she doesn't need to pump so hard. Okay, so we give her some adrenaline, we give her some calcium. The most important thing probably is to phone a friend and say, this woman is super sick. She's sliding on multiple pressors and inotropes now, and I think we really need to think about ECMO. We have a discussion. We decide we're going to intubate the patient to try and help that left ventricle, and we'll come to that in a moment. And we, for what it's worth, we'll try and diurese her a little. So she's stable for a little while. We intubate her. They say that ECMO is going to take too long, and we ought to try and stabilize and move to Sydney. So we intubate her, and for half an hour, 40 minutes or so, she's stable, and then her blood pressure starts to slide. We can see it sliding further. She arrests. We have Lucas. She has a good end-tidal CO2. She has something akin to this as her arterial line trace. So that's actually a pretty good systolic pressure, you'd think. That's great. But if you look at her diastolic, it's 25. That's not great. The reason that's not great is LV perfusion, as we said, occurs during diastole. And the perfusion gradient is that difference between your aortic pressure and your left ventricular pressure. So during systole, they're the same, but during diastole, there's a decent difference, which is great. That's what we want. So as your diastolic blood pressure drops and your left-sided pressure goes up because you're in failure, that perfusion difference drops. Again, your perfusion drops. So what we really want is a diastolic, best estimates sort of suggest above 35. Okay, there's a few trials, not many, of patients who've had invasive monitoring during cardiac arrest. And patients who had a calculated coronary perfusion pressure of less than 15, no one got ROSC at all. So only those with a perfusion pressure above 15 had a chance of getting ROSC. Okay, because you need to perfuse that ventricle for it to beat again. How can we do this? We actually don't know what the best thing is. You know, we still give adrenaline and arrest despite the sort of paramedic 2 trial. And the goal there is to increase systemic vascular resistance, increase that diastolic pressure to perfuse the left ventricle. So really we want an alpha agonist. Okay, so could we try NORAD? Could we try vasopressin? There's the VSE trials from Europe suggesting that might be helpful. More adrenaline. Riboa, which has been trialed in some animal models and stuff, actually it's essentially an intra-aortic balloon pump, but just to try and increase that systemic vascular resistance so that you have a chance, and there's some promising stuff there. People did talk about abdominal compressions, interspersed abdominal compressions, which was a thing. Not sure. We don't really know. But it's a balance, because diastolic blood pressure is actually also the principal determinant of left ventricular afterload. So you could increase your diastolic blood pressure loads, but you're also now perfusing the left ventricle, but giving it more work to do, and that you don't want to do. So Afterload is again, there's varying definitions, but it's essentially the wall stress for the left ventricle required to eject the stroke volume. And it's proportional to your pressure times the ventricular volume divided by its thickness. But the important things for us is it's the pressure it needs to generate minus your intrathoracic pressure. Okay, that's key. Others that, as I said, a dilated, thin-walled ventricle will have high wall stress. Sounds like everyone you know with ischemic cardiomyopathy. So what happens? You don't need to read this, but it's there and I can send it out if need be. But essentially, you get pulmonary edema. You breathe harder because your lungs are wet and heavy. You're generating a massively now negative intrathoracic pressure, which is sucking on that left ventricle and holding it open, preventing it from squeezing, okay? That also sucks more blood into your cardiac system, into your RV, which passes it to the LV. So now you've got higher preload, so now you've got more to eject from the left ventricle. So what happens? Your pressures rise, you get more pulmonary edema. So then you breathe harder, okay? And then your afterload increases even further and your left ventricle fails even more. And you suck more blood in and it's a vicious cycle. So this is why we use PEEP and positive pressure ventilation, because now you're switching from a negative intrathoracic pressure to a positive intrathoracic pressure, and it really helps left ventricular afterload, and it's great apart from anything else. And it also helps, as we know, move some of that pulmonary edema we think out of the alveoli. So that's why CPAP is great, and the LV loves CPAP. Good. Other things we can do, GTN, vasodilators and so on, if your blood pressure is going to handle it. Okay. And we know there are those patients who come in flash pulmonary edema with massively increased systemic vascular resistance and afterload, and they're the patients who benefit really well from CPAP, BiPAP, and vasodilators. So, in terms of supporting your left ventricle, as a summary, you want to optimize your preload, augment your contractility, reduce your afterload, so long as you can maintain your perfusion. You may need to use some noradrenaline or something to maintain perfusion, but you've got to make sure that you're doing everything else right and balancing it, okay? As with anything, especially with cardiogenic shock, early recognition is key, and early referral and discussion with specialists is key. So consider mechanical support. Have you asked? And we say wean inotropes and vasopressors early because we know that patients who are on these for a long period of time, especially if they're not required, increases their mortality. So, what happened with our lady? Sadly, we knew from the moment she arrested, we'd watched this lady's heart fail over the last couple of hours. We tried everything we could medically, and we weren't going to have any mechanical support coming. So there's nothing we could do. And you knew when she arrested that even if she'd had the best arrest care she could, we wouldn't get her back. And sadly, she had an unsuccessful resuscitation. So case number 2 is a 58-year-old female with pulmonary fibrosis and pulmonary hypertension. She came to ED a few days before. She was tachycardic, had chest pain, had negative ECG and troponin. She was discharged on metoprolol for tachycardia. I'm not going to say where this was, but it was a long way from here. 3 days later, she comes back hypotensive, confused, and multi-organ failure. So, questions. Is this cardiogenic shock? Well, hint, it's a talk right now on cardiogenic shock. So yes, this is cardiogenic shock. What's the sky stage? Well, she's pretty sick. She's probably C at the moment. Is it LV, RV, or biventricular? I mean, in her history, you've got some thoughts as to what it could be, but you know what to do next. What happens next? Well, you know what happens next because it's the same old story. She is treated as septic shock. She gets a lot of fluids and antibiotics. So let's talk about the RV, the other guy, okay? It's classically the forgotten ventricle, okay? And it's not as well understood or talked about as the left ventricle. Does anyone know who these guys are? Yeah, these are the original Michelin men from the 1800s. They look like some kind of scary fat suit Nazis. So the right ventricle is not important until it is. And once it's important, it's everything. The way you die is from right heart failure. It's a very good talk from Michael Pinsky. If anyone's interested, I'll send you the link. RV failure is often called the final common pathway because we're really good at treating LV failure, and we give them ACE inhibitors and beta blockers and stuff, and they're all walking around having a good time. And then they develop right heart failure, and we're not very good at treating that. And essentially, that's the way that most patients with congestive cardiac failure will eventually pass. It's a clinical diagnosis of two main things: systemic congestion, which is due to elevated right atrial pressure. Remember, that increases all-cause mortality and cardiogenic shock as it linearly goes up, in combination with structural or functional abnormalities of the right heart, echo. Okay, so you've got everything you need to diagnose this. So let's have a look at our lady. She's got a dilated IVC, so she's got elevated right atrial pressure, which is not a surprise. And you can see that her right ventricle is massive and is pushing on the left. Again, I'm not going into the echo stuff in detail, but we now know, is this LV-RV? It's clearly RV failure. Again, let's go through them. Preload contractility, afterload. The right ventricle is intimately linked with the pulmonary circulation, and probably the most importantly, it regulates its pressure principally through its afterload, through the pulmonary vascular resistance. Okay, it's really preload tolerant actually under normal conditions. As I said, you give patients fluid, they develop pulmonary edema before they develop sort of systemic edema. If under normal circumstances, it's fine with pressure, with volume, but it's weak and it's thin-walled and it can't increase its contractility in response to increasing afterload. The RV absolutely hates pulmonary vascular resistance. It's perfused through systole and diastole, which is great until you get systolic hypotension. So, RV preload. Normally, the LV is a sort of donut, if you look in cross-section, with this sort of croissant of the RV sat on the outside, a bit like an afterthought, okay? And under normal conditions, as I said, it tolerates volume very well, but we know our patient has pulmonary hypertension, and RV dysfunction. So what happens when we give her fluid is the right side picture. The RV dilates, and because the two of them live in this pericardium together, it just fills up and it pushes the left ventricle, the interventricular septum into the left ventricle. This is now reducing left ventricular filling and then left ventricular stroke volume. So then you're going to reduce your cardiac output. Okay. The other thing that it does is it increases your right atrial pressure, which we talked about. That causes backflow into the systemic circulation and turns you into a Michelin man. Okay, your internal organs now look like this. Your kidneys stop working, your liver stops working, your gut stops absorbing things, your legs get puffy, you get very sick. So our hospital gave some fluids to this patient, hoping to increase blood pressure, but the BP remains low due to everything we've just talked about. And as I said before, our perfusion is through systole and diastole. So let's talk about RV perfusion. So again, it's that difference between aortic pressure and right ventricular pressure. And if your right ventricular pressure is 25/4, that's great. That's really good. You know, you could tolerate quite a bit of hypertension. But if you've got pulmonary hypertension, okay, and RV dysfunction, and your RV's hypertrophied and is now making high pressures, and your pressure's at 65/20 or so, you're going to need a really decent blood pressure to perfuse during systole and diastole still and maintain that perfusion to your RV. So our patient with a blood pressure of 60 systolic is not perfusing during systole anymore. And they're not going to cope with that very well. The European Society of Cardiology recommends a pressure of 40 above your pulmonary pressures. So you think that's a systolic of at least 105, always, to maintain good perfusion. So in terms of supporting the blood pressure, which is the most important thing we've got to do in patients with right heart failure, is to maintain that perfusion. You want to increase the systemic vascular resistance to increase their blood pressure. There's a caveat to this, which we'll come to in a moment. You need appropriate vasopressors, plus minus inotropes. Our patient is deteriorating. They're more hypotensive. They've given them all this fluid and all this stuff, and they think, oh gosh, she's super sick. What should we do? Oh, she's confused. We should intubate this woman. So what happens now? She gets intubated. She dies. Someone starts some CPR. They give her a ton of adrenaline. She gets ROSC. Happy days. But her blood pressure is still low. What are we going to do now? Let's give her some NORAD. So they give her a bunch of NORAD. Line her up. Call retrieval. This woman's died. She's now got ROSC and she's having NORAD, and the doses just keep going up and her blood pressure is still rubbish. So where is she now? Well, she died for a bit, so she's She's got the A modifier, and she's pretty sick, and she's on sort of escalating doses of NORAD, so she's CD territory, and she's not getting better. So, RV contractility, let's talk about that. The RV contracts in three principal ways. Longitudinal base to apex. You imagine it's just sort of pulling from the apex. And again, I'm not going to go into the echo stuff in detail, but we call this TAPSE, and it's the best measure on echo that we have of RV contractility. And then the other two are probably very important. It's the synergistic LV contraction. So when that septum thickens, it pushes a bit into the RV too. So it's actually helping both the LV and RV in terms of its contractility. The other is an inward movement of the RV wall. Okay, so if you imagine the RV is like a sail on the LV, when that donut contracts, it's just going to pull the whole wall of the RV towards it. And so that helps. So the LV accounts for 1 to 2/3 of right ventricular contractility, which is great because it means increasing LV contractility for us will increase your RV contractility. And the RV doesn't really struggle so much as a contractility thing under normal circumstances. So she'd had that bucket load of adrenaline during her arrest. That's now wearing off, and now she's climbing on the NORAD. So we should probably do something for her contractility. But her contractility can't keep up with her afterload. And her afterload, which is principally from her left atrial pressure or pulmonary vascular resistance, and in her case, it's going to be the pulmonary vascular resistance with her pulmonary hypertension. Gradual increases in these normally will lead to compensatory right ventricular hypertrophy, which is great. It's really good. It allows that RV to produce those high pressures. We're very happy with that. But if we increased all your pulmonary pressures all of a sudden, today, you'd just die because your RV can't take it. So this is why massive PEs kill people. So she can't increase her pressures properly on her own. She needs to reduce her afterload. We get, as I said, left atrial pressure will increase in left ventricular failure, and pulmonary vascular resistance principally influenced by stuff in the pulmonary circulation. But there's a lot of things that affect your PVR. So hypoxia will make it worse, acidosis, hypercapnia, increasing alveolar pressure, such as when we intubate people, we'll put them on CPAP, BiPAP, and high and low lung volumes. Because if you imagine, if you inflate that lung massively, you're crushing all those vessels and the resistance increases. Same, if you let that lung collapse, it'll crush those small vessels, and the same thing will happen. So we said before that we want to increase our blood pressure so that we perfuse the ventricle, but we want to use appropriate pressure. So what would be great is something that increases systemic vascular resistance and reduces pulmonary vascular resistance. That would be awesome. So we can have a look. These are the pressors and inotropes that we typically use. And you can see we have the PVR effects and the SVR effects and something called the PVR to SVR ratio. And we want a low PVR to SVR ratio. So we want something like vasopressin, which doesn't affect the PVR at all, but it increases your SVR. Fantastic, great. Adrenaline is pretty good, tends to reduce PVR at low doses and increases systemic vascular resistance. NORAD is good until it gets to very high doses, and then there's evidence that it probably increases your pulmonary vascular resistance. Milrinone is good, but it does drop your SVR. Dobutamine the same, so you got to think about you might need a pressor as well as those. And phenylephrine, if anyone uses that, is terrible, and metreminol not particularly good, so I wouldn't use those. Other things we can do to reduce pulmonary vascular resistance: oxygenate the patient, try and fix the CO2 and the pH, optimize that lung volume, and then use some inhaled pulmonary vasodilators. So this would be like nebulized GTN, because GTN is essentially metabolized to nitric oxide. So rather than your fancy ICU nitric kit, you can nebulize GTN, or milrinone, okay, which again will dilate the pulmonary vascular resistance. 5 milligrams every 15 minutes for these. It's pretty good. I know Cliff's got an excellent thing for massive PE, which includes these in their thing from Northern Beaches. So if you can, don't intubate the patient, because you're now in that place where you've increased the pulmonary vascular resistance further by the pressures, then you've got to try and ventilate the patient, so you've got to have higher pressures, and it becomes very complicated. So if you can, try not to intubate them. If you do need to intubate them, do everything else first and have stuff ready to go, and have some push dose adrenaline and so on, to try and maintain that perfusion after they clearly dump that pressure. So no talk on RV failure would be complete without mentioning the spiral of death, okay? And there's loads of diagrams out there, and it's not really quite the spiral, it's more of an interlocking web of things because everything's affecting everything else from what you can probably gather from what we've said already. I've sort of simplified this a little bit, but essentially you dilate your RV, you reduce your LV output, you then get hypotension, you then don't perfuse it, then contractility drops, then it fills some more and it dilates some more, and the whole thing happens. It gets worse and you get the picture. These patients can deteriorate very rapidly, and it's important that we recognize early and do the appropriate interventions. So in terms of supporting the RV as a summary, support perfusion, number one, is the most important thing. So like NORAD, bit of adrenaline, maybe vasopressin. You might want to increase their contractility. This is where I look with echo, and if their TAPT is down, I'll give them probably some adrenaline or something on top. Reduce their afterload, so optimize all that metabolic stuff. Try and avoid intubation, pulmonary vasodilators, so GTN, milrinone. You might want to consider diuresis, depending on what you think their preload status is. We'll go over that in a second. Don't fluid resuscitate cor pulmonale. It's only going to make things worse. Obviously, treat the cause. If it's a right ventricular infarction, then need PCI. If it's a PE, then think about thrombolysis. And consider mechanical support early in ECMO. Now, there's a lot of stuff about the fluids in RV failure and guidelines and so on. So let's just have a quick think, because so the Ferrari trial from last year did diuresis versus volume expansion in patients with intermediate risk PE. The result was not a patient-centered outcome, but it did reduce pulmonary pressures quicker with diuretics and quicker normalization of metabolic or biochemical markers. There was no mortality difference, but this makes sense to me. Your RV is big and dilated. Diuresis, probably good. Now, if you think the patient is globally hypovolemic and would benefit from fluid, then most of the guidelines will say give a fluid bolus and see what happens. But this makes sense to me. Right ventricular infarction. The traditional teaching is that these patients are preload dependent because their contractility is shot because they've infarcted their RV. But this actually comes from a pretty small case study, and a meta-analysis recently has showed that, of more patients, showed that actually these patients tend to tolerate GTN, which was sublingual, not IV, but they tend to tolerate it pretty well, and there was no significant adverse events from it. If they do become hypotensive and you think they're a bit down on fluid, then you can give them a little bit of fluid, and that's okay. I think there are patients who talk about the hypovolemic right ventricular failure. These are the sort of patients to think about, but if you're that hypovolemic, then you're not really in a right ventricular failure because you're not congested. It's just a thought. So what happened to our lady? We stopped the fluids, we gave her loads of frusemide, gave her some calcium, started low-dose adrenaline, and stopped a NORAD, and gave her some nebulized GTN. Everything improved. By the time we got there, we basically weaned her adrenaline off. So this is awesome. She's gone from very, very sick to pretty okay. And a few days later, she was extubated and discharged. So she did really well. RV failure is very, very nice to treat, satisfying to treat. So quickly, LV on the top, RV on the bottom. Okay, we've been through these. If I was to summarize it as to one most important factor for each ventricle, it would be that the LV hates impaired contractility. Its whole job is contractility. So if you take that away, infarct it, for example, or give it myocarditis, it will really struggle. And the RV hates afterload, okay? If it's got a reasonable afterload, it'll handle anything else, okay, if the afterload is low, but if not, it really struggles. The last thing to consider is that all the treatments and stuff that we think about, with the exception of thrombolysis probably, are a bridge. They're a bridge either to recovery if the patient's got myocarditis, to heart transplant if they're a candidate for that, to mechanical support, whatever it may be. Even those are a bridge to PCI, a bridge to whatever. The mortality from these patients, we've already said, is very high. The morbidity is very high. Even if they survive their cardiogenic shock, it may be that they are very disabled. Sometimes we need to think about palliative care, and when should we instigate that, and should we speak to them early, find out what the patient's wishes are. So cardiogenic shock has loads of causes, which we haven't been through. Mortality is still high despite all these advances in care. Over 50% of cases involve the right ventricle, which is important because RV failure is complex and management is difficult. Early recognition and specialist input is key. Optimize your preload, your contractility, and your afterload, and make sure that you maintain perfusion. Going forward, there's a lot of talks worldwide about shock services or shock networks, a bit like we have with trauma networks and so on. We've recognized the value of PERT response teams, PE response teams in hospitals, and this is a similar sort of hub and spoke model for cardiogenic shock. I know that in London they already have this at Barts, where they have 24-hour access to all the services required, and anyone can make a shock call from a peripheral center. So this is where we're going. Now, in New South Wales, and I'm sure the consultants probably know this better than me in more detail, there is anyone with cardiogenic shock, you can call this number, which is the ECMO Centre, VAR ACC. And if you could boil this talk down to just call this number if you think someone has cardiogenic shock, and they will tell you what to do, and they will walk you through it. And if they need other services and input, then they'll do that. Okay. Thank you very much. I appreciate there's a lot, but thanks for your time. And has anyone got any questions?